Hi everyone, thanks for joining us this evening. So we'll get started and just go over some basics before we really get into the meat of the talk. So the talk is about equitable care in early detection and diagnosis for LGBT patients. So to that end, let's get a feel for the room first. So I'll give people a chance to log into menti.com with that code and just pop in how they're feeling about their awareness on this sort of topic, their knowledge in relation to LGBT cancer care, and also their comfort around it and around dealing with these kind of patients. And I'll give people a minute because I realize some people might still be logging in. Cool, it's good to see some good levels of comfort. That's reassuring. I'll hold out just another second for any more if they want to log in and put some in. Nice. Okay, so it's good to see that everyone's sort of at a midpoint, which I'm guessing people are a little bit unsure, know some stuff, want to learn more, which is obviously why you're here this evening. So it's a good starting point to go from. So the next thing we're going to do, just to get a feel for the room, just get people's thoughts on this topic. So feel free to throw in a keyword, either a key sort of question you're worrying about, or just generally, again, something you know of this topic, so we can kind of see where people's minds are at. And again, it's all anonymous, so just throw some words up there. Yep. You can see excited in the chat box, so that's good. Yeah, supporting trans patients, we'll go over quite a lot of that this evening. A lot of terminology, yeah. Again, terms, we've got people interested in this, which is good. We're seeking equity. See terminology coming up a lot, so it's good to know. We'll go start with that this evening. Yeah, highly important. I'm glad we all agree with that. Fantastic, that's a great start. Okay, so to that end, let's get straight into it with terminology. So how do we define LGBT? So LGBT is an initialism and it refers to lesbian, gay, bisexual, and trans. And when we break this up, we see LGBT refers to sexual orientation, whereas transgender is a gender identity. So there's a distinction to be made there. You might also see it written in multiple different ways. So you might see it with a plus at the end to be more inclusive of others. You can see it with Q for queer. There's I for intersex, A for asexual. There's 2S, which is two-spirit, which is more of a culturally based third gender. But the point here is many different iterations, usually just to try and be as inclusive as possible. But if ever you see these, don't be sort of taken aback by them. LGBT is sort of a good inclusive standard, and you can feel comfortable using that one out in the field. So let's break down those sexual orientation and gender identity. So we'll start with sexual orientation. So I want to put it to the room. How many people do we think identify as a sexual minority? So that's anything other than straight. And you can just vote away there and we'll see all these little dots collect. Oh, some high votes for 5%. Ooh, quite a lot for 5%. Okay, so that's definitely the majority we're seeing. So the actual answer is closer to around 4%. So we're not far off by hitting 5, so that's good. And then a slightly different question, how many people do we think who identify as heterosexual have had a same-sex experience in their lifetime? Okay, so we see some 5%, probably in line with what we saw before. A few on 11%. Okay, so we're between 5 and 11. So the closer one is actually about 11%. So we'll get into why that's important now. So When we define sexual orientation, we define it as how someone feels sexually about different genders. And it's important to note activity doesn't always mean orientation. So this is why it's important to let people define who they are and explain what they're up to, just so we're not making assumptions based on the labels that we have. When we look at the GPPS, we can see that about 4.2% of people identify as a sexual minority, but there's a 5.5% of people who prefer not to say. So there might be some people in that category as well, but we can't really make assumptions about that right now. So when we let people self-identify, we also capture any other risk behaviors that might be going on. And this is important because, as we see, 11% of straight people have had that same-sex activity. And some people may be having same-sex activity for other reasons and still identify as straight. And this could be things like sex work or other reasons. So if we think about it by age, so younger people tend to identify themselves as a sexual minority. I just want to point out on this, it may look like that over a lifetime, this is going to sort of decrease, but actually we see this more of a generational effect and people are more likely to come out and stay out at this point, which we would make the assumption it is to do with the social sort of ethos that's being more accepting of people. We can also see as well from about 25 onwards, there's a pretty standard pattern of how people identifying as gay, bisexual or other. And then if we look at it by ethnicity, we can also see that the highest rate of responders of sexual orientation is mixed and multiple ethnic identities. But also I want to point out this other category. So because there's quite a lot of responses in other and other, that gray bar, we have to be thinking about, okay, so these are people that may identify in a certain way that our questions aren't capturing effectively, but they're still identifying something other than straight. So we have to consider them when we think of our health interventions. And if we look at South East London specifically, you can see that you're overrepresented in every category. So that's why it's important to do this work and make sure that we're supporting all of our patients. So here comes one of those first check-ins. Just see if there's any clarification needed. I'll pause for a second and just see if anything comes up. And if not, we'll just jump straight into the next section. I'll give it a second. And also feel free to use the chat box if it's easier for you, and Zara can keep an eye on that for me. Okay, I'm seeing nothing so far. Oh, sexual minority. Yeah, so sexual minority is something, it's a label that we use for anything other than heterosexual. And the reason we do that is to be as inclusive as possible for any other sort of sexual orientation that may come under that umbrella. So this could then be used for gay, lesbian, bisexual, pansexual, all these other labels that exist. Okay, so let's move on to gender. So we've done sexual orientation, now it's gender identity. So the first thing obviously is the difference between sex and gender. So sex being biological characteristics that define us as male, female, or intersex, sometimes known as differences in sex development. And gender is more to do with the social construct of what we see as masculine and feminine. And then we code the way that we behave and the social rules and relationships we have sort of into those categories. This then gives us labels like transgender and cisgender. So transgender we've probably heard and maybe roughly know about, but cisgender might be new to some. So I'm just going to define exactly what they mean. So when we talk about sex, we tend to say in the community, we tend to say your sex assigned at birth. So this was the declaration a doctor made when you were delivered based on those kind of biological categories and features we said. And gender, again, is that social construct. So for cisgender people, their sex assigned at birth would align with their gender. So it's pretty much a straight line down. So this would be a cis male and a cis female. And then for a trans woman, this is someone who would have been assigned male at birth, but then has female gender. Then it would be the other way around for a trans man. And then we have non-binary people. I put myself in that category. So they can be identified as male or female at birth, but have a gender that sits outside of the typical categories of masculine and feminine that we see. You might see this in some other models like a genderbread person and some other ones existing around, and they tend to plot this on a straight line. But in my view, that sort of misses the point of gender. Because what you do when you do that is you end up giving yourself the straight line between male and female, but you're missing out on what I think is a broader spectrum of gender. So this is a model that I use and have created for this purpose. So they exist in society as third genders, and they tend to be quite culturally tied and have quite a rich history. And we've got Two-Spirit of North America, Fafine, we've got Mahu, there's the Bonesha, which is more of an Eastern European one, Hijra in India. So these are third genders that exist and they're socially reinforced and categorized. So it's unfair to put them between male and female, and sometimes doing so on that 1-point scale creates some kind of bias in the way that we then expect androgyny from people that may identify as non-binary. In the middle, we also have people who have no gender. They don't really relate to any gender labels. And the reason it's in the middle of this graph is so that as the graph radiates out to the edge, the feeling of gender gets stronger. And what happens when you put it on this kind of model is people can have more flexibility about where they place themselves. And it allows us to open the way we think about gender as rather than it just being a sliding scale between male and female. And when we do open our mind in that way, we can see that actually non-binary as a label is quite broad. And I think people need to appreciate that that can include agender, third gender, people that may be feeling a little bit more androgynous. So if someone presents you as non-binary, again, it's not making assumptions, it's letting them define how they are. So gender dysphoria is another common label that we hear, and this sometimes is seen as the motivator towards transition, and it's definitely still a diagnostic category. And it's the feeling of discomfort or distress that comes from the lack of alignment between someone's sex and their gender. And we can see this in a physical way, it can also be mental, and it could be social. And what we mean by social is the way that we are seen by the people around us and our interactions, and is our gender affirmed by the relationships we have in society. So another poll for you, how many people do we think identify as a gender minority? So again, anything other than cisgender, so someone who sex aligns with their gender. Okay, yeah. All right, so yeah, it is 4.5%. Yeah, you got it. So with that 4.5%, I do want to make the distinction that this actually is also referring to anybody that's in that sort of broad spectrum of gender other than that discrete male and female category. People that are sort of more of a binary transgender, so a trans man and trans woman, that percentage you might see it out in the field as being a little bit less. Okay, have we got any other questions after that? I'll give it a second in case anyone's still tapping away.
I've got none on the chat.
Awesome. So we'll crack on. So we'll get into pronouns. And this is, I know, where a lot of people get a bit concerned. So pronouns are nothing new. So let's start there. So it's a feature of language that we use, and we basically use it to replace a proper noun in a sentence. And it's important when we think about pronouns in a gendered form that we use them effectively and appreciate that they can reinforce someone's identity. And that respect that we give people is quite important, not only when we're dealing with them, but also when they're not present, because primarily when you're dealing with someone, you'll be using their name, but when they're not there, that's when you're more likely to use that pronoun. And also it shows true respect if you're continuing to use their pronoun when they're not present there to check you. So the most common pronouns we see are she, he, and they. And they is the one I use. So when we think about it and how it features into language, a lot of people get stuck on this idea of they being a plural, but you is also used in singular and plural. And we know by context and the way that we're using it. So these pronouns are pretty interchangeable. And this is what this fun little graphic's meant to show, that actually they can switch out and it doesn't really change the feature of the sentence. And I would encourage people to remember there's even the example of, say, for example, you're waiting for an Amazon delivery and you go out and you miss the person, you check in with your other half. Oh, did they arrive? What time did they come? I'm sorry, I missed them. We do it all the time. When we don't know someone's gender, we naturally defer to the third gender of they. And I would encourage people to remember if people present as non-binary or just choose to use that pronoun, it's entirely valid and it's okay to do so. So how do we kind of get to that point of talking about people's pronouns? So if you think it might be worth doing it with a patient front off, so you identify they may be part of the LGBT community, you can try using your own and just introducing them. And that kind of shows, okay, I understand what these are and I'm going to support you with this. And also you should be trying to do this with every patient, I would say, but I appreciate that might be tricky in some cases. Another way, if you're not feeling very confident about bringing it up in a conversation, you can put it on a name badge. And that's another way that you can sort of non-verbally just put that out there that you're creating a safe space. So how many people are afraid of making mistakes when it comes to pronouns? This is just a yes or no, get a feel for the room kind of question. Okay, got a no in there, that's good. but majoritively yes, which is what I expect. And I think it's, you know, it's a pretty standard thing at this point that we're all a bit afraid of, in all cases, upsetting someone. So what happens when you do get it wrong? So what I would suggest is this AA double C method I put together. Now the A's go outwards and the C's are more reflective. So first thing to do is acknowledge your error and make your apology. Don't oversell the apology because that makes some people feel uncomfortable, but just appreciate, yeah, I got it wrong. Okay, and then you move on to your next step, which is to ask. So involve the person you're learning and just check you're getting the pronouns right. Make sure that you're actually on the right path to making them feel good. And then comes the reflective process. So correct yourself, use their pronouns correctly, make sure you're showing some changed behavior. And then the last thing is commit. So make sure you're committing to that new pronoun you've just learned and you're committing to it the whole time, because you shouldn't really rely on other people to keep correcting you. That said, some people's pronouns might be changing over the time you know them too. So it's always worth checking back in, or if they correct you again, it's fine. But again, making sure that you're making these efforts to check in and just make sure people are feeling validated. So I'm just going to pause if there's any other questions about that, because I know pronouns can be a tricky one. And again, hopefully we'll have some time at the end to kind of go into them a little bit more and generally in a conversation way.
There's no questions on the chat, Stuart.
Cool. So let's then plot out what the general LGBT healthcare experience is. So there's a lot of stats here I'm going to run through quite quickly, but they just give you a feel of what it's like out there. So 23% of LGBT people say they've witnessed discriminatory remarks from their healthcare providers. About 14% have avoided healthcare. Of those who are trans, that goes up to 37%. 38% of trans people who did attend had a bad experience. 19% of LGBT people are not out to any healthcare provider. In our own survey, we saw that 31% of trans cancer patients went out, which is quite worrying, I think. And then generally, 41% of trans people feel like their general healthcare needs aren't understood. And there's another thing to point out here as well. Bisexual people actually end up scoring quite badly as well, more so than their gay or lesbian peers. And that sometimes gets lost in the data. So it's thinking about every single person that comes under that umbrella and realizing they have their own sort of unique issues they're trying to overcome. But how does this apply to cancer? So in the CPAIRS, we can actually see the they only monitor for sexual orientation currently, but we can see that there's over 20 questions where there's a significantly poorer score, and this can go into things about hospital staff talking as if they're not there, not being asked for a preferred name, less privacy about talking about their issues. We've also got less attitude with respect. And also there's an important one about poor communication between hospital and their GPs. This obviously comes into what we're talking about today. And then generally an overall poorer rating of care. So not great. But ultimately, we don't expect doctors to be going out of the way to do this. So why is it happening? So one of the things to be thinking about is implicit bias. So these are the attitudes and stereotypes that we kind of take in from society and they're coded into us, but they end up affecting the way that we actually deal with people, even when we don't intend them to. And to give you an example, if we think about the EMIS system, so the labels that we use in EMIS when it comes to transgender people still tend to be quite outdated. So we see transsexual used. We've got risk categories of sex with a transgender. Not only is that sort of grammatically incorrect, the way we talk about transgender people now, but we're thinking about, okay, well then what does this kind of put in the back of our brain in the way that we're thinking about these people and the way they're going to be interacting with them? And then some other ones to think about are cisgender assumptions. So assuming that everybody is cisgender and they're making those assumptions and therefore not really giving people the opportunity to tell you who they are or how their body works. And then we also have heteronormative assumptions. So this is the idea that everybody's going to either have or be pursuing a heterosexual relationship. And this comes up quite a bit later in the talk. So when we think about biases as well, we can't think about them as isolated things. They do have compound effects. And Kimberly Crenshaw put this forward when she was talking about her own experiences of being a Black woman and having issues accessing services and being in society as a Black person, but then also as a woman, and how those two things interact to make being a Black woman in society a unique form of oppression. So then when we're thinking about LGBT people, we have to think about other things that might be going on. So, okay, are we supporting them in this, but are there also other cultural factors involved? Are there other socioeconomic factors? What kind of things can pull together and create barriers to a person's care, or what additional support might they need or social prescribing might they need in order to reach that equitable level of care that we're after. And it's important to think reflectively, think about what you've had to overcome and what way this may apply to you as well, and see if there's any ways you can relate. And it's important as well when we're making these kind of solutions that we're thinking, okay, yes, we want to focus on one issue, but maybe we need to take a sort of broader scope too, so we can actually make sure that one thing isn't affecting another. So there's a brief pause because that was a lot of theories and terms, see if there's any lack of clarity, and if not, we'll get into the meat of the talk.
There's no questions at the moment on the chat function.
Cool. I'm just going to double check on the Q&A. So what is MX? I'm assuming this refers to, I'm just going to bring that up on there. So MX referring to the title. So we have Mr., Mrs., Miss. I'm assuming that's what we're talking about here. And it's just a gender neutral form. So some people may want to use that on their records. Not everybody will, but it's the one that people go to so that it's a way to sort of put a gender neutral title on them. So that's that one, yeah. For the title Mac, I'm not sure what that refers to, whether that's the same kind of thing. So feel free to either pop another question in or put a clarification in the chat, and we'll come back to it when we next pause. Okay, so let's think about this sort of in practice, these things that we've talked about. So Wales Cancer Network put together the Single Cancer Pathway, and the reason I like this is it gives us a really nice pathway towards diagnosis and beginning treatment that also includes quite a lot of attention to the patient interval before the first point of suspicion. So when we think about this from an LGBT point of view, and I look at it, I see a lot of potential red flags of things that might go wrong or potential breakdown in service. So I want to go through some of them and kind of think about that from a patient point of view. So first thing in population awareness is there's a general lack of LGBT health messaging out there. Think of when was the last time you saw something about LGBT health that wasn't sexual health. And then also there's erroneous intra-community health assumptions. So women who sleep with women, that's what WSW means, are often told that they don't need cervical screening, and that's something that then perpetuates through the community. We also see a lack of high-risk HPV awareness in men who sleep with men, especially HIV, MSM, who are at increased risk of anal cancer. So these kind of things, there needs to be more public health messaging to support them. Also, I know this graphic at the top is a little bit small on these slides, but there'll be a handout going around after this talk so you can reflect on this. So then obviously a lack of awareness is going to affect patient appraisal. So how are they going to attend these screenings? How are they going to monitor themselves? And then also how are they going to manage the sort of risk and the behaviors that we have out in society? And we know that the LGBT community has high rates of smoking and drinking, and these obviously can have negative impacts on cancers. And then when we come to screening, there's multiple barriers to cervical screening. We'll go over some of them later. And then also we know there's lower rates of screening uptake in LGBT patients. And this sometimes is down to poor experiences, again, that misinformation, or not knowing what people are actually eligible for. And we also know that because of the way the NHS record management works at the moment, trans people may not even be called for the correct screening. So when people do attend GP surgeries, so firstly, we see a lot of delay and avoidance. So that's obviously not great when we're especially thinking about something as time sensitive as cancer. And also we see insufficient SOGI monitoring. So that refers to sexual orientation and gender identity monitoring in the NHS. So this gives us an incomplete picture of health, and it really makes it quite difficult to make sure that we're actually asking the right questions of people. Another thing that we kind of see at this point as well is something that's known in the community as the trans broken arm syndrome. Now, this comes down to the erroneous assumption that anything related to someone's health might be related to their transition. And this might be just because there's a lack of confidence about knowing about trans health and hormones and the effect on the body. But what happens for the patient is they feel that they're not being heard or not being taken seriously or understood, and they're being sent away, for example, oh, I've got migraines, are you sure it's not your hormones? Those kind of things. And then this again, not only erodes trust in the health service, but creates further delays. And also if it's anything cancer related, can lead to further proliferation of disease. And it's such a common thing in the community that we talk about, there's even cartoons made about it. So I'll let people kind of pause and sort of take that in. But this is how much of a standard concept it is to us, and something we have to really translate to healthcare. So then what happens when we actually do refer people on? So if we think about a vague symptom pathway, so this is quite concerning when we think about trans patients, because if we don't know their correct anatomy, how do we know if we're sending them for the correct screening? And there have been some case studies where people have been sent for the wrong screening and it's led to furthering of the disease and sometimes death. So it's really important to be giving patients an opportunity to tell you their anatomy, so we're sending them to the right places. And this is why opportunities for disclosure are really important, because I'll get into why in a minute how NHS records work when someone does transition, but you may not have a full picture of health on their records. So these points of disclosure are really, really important. But what if you do know someone's anatomy and you're sending them for the right screening? Thinking about trans people again, is that a very gendered diagnostic environment? Are you sending them for a gynae cancer environment? Is it going to be very women-centered? Is the clinic going to be very women-centered? Thinking about these kind of things, is that person going to continue with their treatment and screening if they're not going to feel comfortable in that space? And that pink washing, especially we see it in breast cancer, can be quite dysphoric. And we also see this in women who sleep with women, so that's lesbians and bisexual women. They actually suffer with this quite a lot as well. And I would encourage you even just to type in breast cancer on Google and everything's pink. So it's about thinking, okay, well, how are we actually appealing to people and making sure that they can access that information? And then lastly, because it came up in the CPES talking about discussions between the hospital and the GP, I just want to point out what happens when it comes to treatment planning. So for some trans people, there may be some considerations related to their gender treatment in relation to their cancer treatment, and there may be a discussion that needs to be had around that. So there is actually an MDT in development for this. It's still in business case level, so it may take a while to come through, but up until that point, we have a colleague that again will be on the handout that you can contact for any specific questions related to trans people and their cancer treatment. So I give it a brief pause there. And then the next step will be kind of going through addressing some of these barriers in more detail. So I'll sort of pause if there's any specific questions. And if not, we'll just get into pulling that apart. And I apologize if anybody can hear the neighbors in their garden.
So there's no questions on the Q&A, and apologies, the kettle will go off as well if anyone hears that. So
modern living, isn't it?
Yeah, it is. So we do have a question. It said, it just said, glad you mentioned HPV, throat cancer must be screened.
Yeah, 100%, yeah. And we're actually, as a charity, taking a look at how we can kind of support with this, and especially with trans guidance, but also making people aware of HPV and where it can be at risk, definitely. So, oh yeah,
sorry,
go ahead.
Stuart. Yeah, there was another question that said, what is pink washing?
So yeah, great point. Pink washing is the term that we give to the sort of over pinking of cancer related information, effectively over feminizing. So you might hear sometimes pink washing used in a different term. We're out in sort of more sort of commercial spaces where you'll see it more about LGBT things. But when we think about it in health related information, it usually refers to sort of over feminizing of information and points. There's also another question I want to pick up on the Menti, which is actually a really, really good question. Does the term trans always imply transition? No. Yes, in the sense of a lack of alignment between sex and gender, and that therefore would make somebody transgender, but the act of transition is incredibly unique to every person. Some people will seek medical transition, some people would just seek social transition, some will seek a surgical transition, but some may seek none, and that's where we find non-binary people typically. So that's a fantastic question. So trans is how we shorten transgender, but we shouldn't always assume that transgender people are in some act of transition towards what we'd see as more of a binary presentation of gender. Great question, really great question. Do you think MDT should include representation from third sector? This is a really, really good question as well. So the person who's putting the MDT together is actually a trustee for our charity. So this is how we have very good links with them. And we've been able to sort of work quite closely in making sure that the third sector is very well linked and coordinating with other larger organizations like LGBT Foundation, Stonewall, etc. So I think it is a good point. And we're also very keen as well, thinking about that MDT, about any sort of particular additional needs like social prescribing that might need to happen, and sort of more community-based support when it comes to trans health. Yeah, really good question. Anyone in the chat box, or we'll move on?
No, you've answered them all. Thank you.
Great. So let's think then about good practice. So we've kind of identified quite a few issues. let's think about how we can sort of deal with them. So first thing, obviously, safety netting. So thinking about transgender patients, maintaining a list of eligible trans patients for screening is a really good way around this, and then flagging their records for when the next screening may be due. And then also as well, giving patients guidance on how to not only check themselves, but also what screening is available to them, where they can go to for this. That's all really, really good things to be thinking about to help transgender patients effectively access something they're completely entitled to, and it should be as simple as their cisgender peers. So let's think about cervical, and we've kind of put that in our head. So we'll start with cisgender people in our community, so lesbian and bisexual women. How many have been told that they don't need cervical screening? Just going to put that out to the room. Okay, yeah, there's some good appreciation that the number's pretty high. So it's up to actually about 40%, but yeah, it's good to see people appreciate that it is an issue. So then if we think about how many people have been refused or discouraged from screening, what do we think that number is? Yeah, again, some high ones. Okay, so we're in the higher ranges. So it's about by 15. Told by who? It would be their healthcare providers or staff nurses, and we'll kind of go into how this happens in a second. So one of the biggest myths that we hear is you don't need to be screened if you don't sleep with men. This is false, but we do hear it quite a lot. And we're supposed to remember that screening is recommended for anyone who's ever had anything in the vagina. So this can be fingers, tampons, toys, lots of things to be thinking about with that. We do see that women who sleep with women have lower rates of cervical screening. And so we have that 37% told they don't need to be screened. And this is that myth, that thing about, okay, well, you don't have a male partner, so why are you here? Like this doesn't need to be done. And then we had the 14% who have been actively refused or discouraged. So this tends to be what we've heard, not only from research, what we've read, but also what I hear when I run my peer support group, is people will be saying, almost pushed into a position of disclosure. Are you sure you're pregnant? Are you sure you're not pregnant? These kind of questions, until someone has to say, well, no, I have a female partner. Oh, well, you don't need this screening. Why are you here? And what that does ultimately is that person not only gets pushed away, but then they go back into the community and they repeat that myth. And then it becomes this sort of thing that spreads. And also we have a negative experience as well that's going to stop people returning. So we have to be thinking about, okay, what information are we really sending people out the door with? And therefore, how can we then expect them to come in for their screening? So on the next slide, we have the same issues in trans men, unsurprisingly. So trans men and non-binary people, AFAB refers to assigned female at birth. So you may see AFAB there, and you also may see AMAB when we talk about people assigned male at birth. So in this case, we're talking about trans men and non-binary people AFAB. So these would be people with a cervix. And then we can see dysphoria from the procedure, dysphoria even from the screening invitations and information, especially if it's quite gendered. Technical difficulties with the procedure can happen. This can be just due to discomfort, not used to having anything inside the vagina. It can also be down to the effect of testosterone on the vaginal tissue. This also can end up leading to a higher rate of unsuitable samples. So it's really important to make the patient as comfortable as possible, so we're not having to do retests. There's also the failure to be called automatically by the system. I'll go into why that happens in a minute. And overt stigma and discrimination, or fear of. So when we think about how to sort of overcome these, things you can do can be arrange the appointment at the beginning or end of the clinic, so they're not waiting in a very gendered clinic. There's also the option to talk about ways to make the procedure a little bit better, like using a smaller speculum, giving people one to take home and practice with, maybe even letting them insert the speculum themselves, and then you taking over from that point. Other thing can be checking the name the patient wants to use for the appointment, or if they want to use their initials instead in case they're afraid of being outed in the environment. And again, that unsuitable samples point, I personally think it's good just to let people know that there may be a need for a retest, and that doesn't necessarily mean anything's wrong, but just so that there's less chance of people becoming non-responders. So if you think about eligibility and how the system works currently, So trans men and non-binary people with a cervix should continue regular screening, obviously. And if they're registered as female, they'll be called in the normal age ranges. Everything's normal. But if they're registered as male, they won't be automatically called and they'll need to request their appointment. And that's where these safety netting ideas come in. So for a trans man registered as male, if you do take the sample and you're about to send it off, it's important to contact the screening lab ahead of time so that they know that you're sending a sample from a male patient with a cervix. I would also back this up by putting it in the information you're sending to. So right patient with a cervix, I'll show you where to do that in a second. And also make sure that you're aware and the patient's aware that the lab will release the results to you, not the patient. So it's your responsibility to check in with the patient, make sure they know that you're going to be doing that, when it's likely to happen, and that you can do so in a timely manner. I've had to support a patient once who had to wait 5 months for their results, and that's obviously not appropriate. So when we put it on the form, it's just put it in the clinical data. Obviously, as well, if you've called ahead, they should know what they're looking out for. But if you put it in there, and I've had this on good faith from a GP who does this quite often for trans patients, this tends to be the way that it works. So for trans women, thinking about cervical still. So trans women registered as female might receive invitations, but they won't be eligible because they don't have a cervix. So when re-registering a patient's gender, you should be contacted for a no cervix confirmation. But if that doesn't happen, this is where they might still get those invites. So you can put in a cease request via OpenExeter, and it's important to try and do so before the cutoff on the P&L so that we're not getting any of those invites sent out that are erroneous. And it might also be worth explaining to your patient, okay, even if you do get this, you won't need to go because you don't have a cervix. There's some information out there currently, which I'm trying to combat with the support of CR UK and my colleagues, about a neo-cervix inside the neo-vagina, which is what we call the new vagina in a trans woman. But this is incorrect terminology, and I would avoid people going with that. There's some work that's hopefully beginning around high-risk HPV in the neovaginal canal, and that's slightly different. But this is all something that's in development, and obviously as a charity we'll keep our eye on, so you can always check back in with us any sort of developments in that point. So other things to be thinking about are bespoke centres and clinics. So these are places that do trans clinics specifically for trans people to attend. Really good example of this is No Barriers Project, funded by RMP. Really good work. Usually these exist in sexual health centres, typically because that's where people feel safe and comfortable when they're LGBT or they go to LGBT centres. It's a great thing because it can make sure you can get over that LGBT phobia issue. People kind of know their service providers. They feel like it's going to be more aware. There is one issue with this, ultimately, that it does put extra burden on the patient because they therefore have to sort of manage two different systems that don't necessarily talk to each other. And there have been instances before where people have been referred onwards because they have a particular issue, and then the GPs found out that way, and the GPs had to kind of call and check. So thinking about, okay, how are we supporting patients? And for me, the long-term goal is making every clinic as affirming as its bespoke centres. So I think it's looking at what they're doing and learning those lessons. But in the meantime, especially if you have a patient that's afraid of doing it in your clinic, send them on to No Barriers, Clinic Q in South, Clinic T in Brighton even. There's quite a few around, but ultimately we'd love there to be more. So there's a pause for questions. I'm going to open up my question tab and I'll let Zara let me know if there's any that come through on there.
So there's a couple of, well, there's a question and a statement. Well, no, there's two questions actually, sorry. How do we increase education to stop this? So this was around the time that you were highlighting around cervical screening, that information given to women or trans patients. And can you confirm this is across both primary and secondary care? So that's number one. And number two, HPV vaccine for all /teenagers. So two questions there.
Yeah, so I'll do the HPV vaccine first because I think that's true. I think HPV vaccine should be available to everybody, and we've obviously seen it with sort of high-risk populations of MSM and the effect there, and we know that it can be really great when administered to youth. So yeah, I think that's something that should be pushed and encouraged in all people, especially when we think about, like we were saying before, where high-risk HPV can turn up. So it's great just to get that jab early. The other thing was talking about when people, I guess, are told misinformation or when they're sent away from screening. Yes, so a lot of the research around this is usually due to primary care and primary care environments, but it also is this sort of this heterosexism and these cisgender and heterosexual assumptions that then impact the patient do happen throughout. And we see it in primary and secondary, that women who sleep with women get these kind of assumptions put on them, and then they are forced into these disclosures and told, okay, we don't need this treatment, etc. So it's definitely something that's pervasive, and it's definitely something that needs education. And ultimately, I personally think it's a quick win. It's just making sure that people understand that that is incorrect and everybody should be having their screening. And it's as simple as that. And that somebody's sexual behaviors, you know, yes, there is the aspect of potentially a lower risk of certain sexual behaviors, etc. But as we've been over before, if you've had anything in the vaginal canal, it's still a risk. So it's just worth attending the screening, and nobody, in my view, should be turned away from screening they're ultimately entitled to.
There's one more question. If a trans woman is invited for cervical screening, surely they would know that they don't have a cervix and so should ignore the invitation. Is the invitation offensive?
So I would assume that the invitation itself would probably not be offensive, because it's going to be using affirming language to their gender. But what I would say is, it may feel slightly, maybe not offensive, but unsettling to know that the system hadn't caught up, if that makes sense. So the system is sending the erroneous thing, and ultimately all trans people know that the system doesn't really support them because of the way that we currently effectively just only register sex and we assume everything from that. So yes, there's also the other point of a trans person should know that they don't have a cervix. But like I said, there's this recent rise in the term neocervix, and this is where we've seen some confusion in the community. And we had somebody, a trans person, actually sort of come to a trans charity with these questions, and I had to step in and sort of make clarifications. And with my colleagues, we've rewritten the trans guidance for screening to make sure that we're clear about what this means, and so that if there is any confusion, people are able to go away and look up, because we don't want people who feel they are confident they know what their anatomy is like, then having these questions of, okay, well, should I be going for this, you know, additional thing or not?
Which is great. So one saying, do you think that virtual clinics might address the problem?
You'll have to kind of define from virtual clinic in what capacity.
So whoever wrote that question, if they can expand on that, that'd be great. And then in the interim, I've got another question that says, the cervical screen request form is unusual in London. CSL, which is Cervical Screening Lab, or for London, is the lab most used, and TQuest is the request form. There's plenty of room to be quite specific, and the patient and around the patient's anatomy. The difficulty is getting information from Open Exeter, who do not recognise a trans masculine patient has a previous history.
Yeah, definitely. And we're going to go into the problem with records in a minute about gender history and how that works, definitely. So and I've got a question as well. So would there be a benefit in using HPV vaginal testing that's being used in SME non-attenders? This is a fantastic question, because this is something me and my colleagues are really like pushing for. So obviously we're aware of the UScreen project and the way that this is being done. And this actually leads into what we're going to talk about next, and the way that these people are being called into the study because they are non-attenders. And they're either done so or they are opportunistically referred by their GP. So this is something that actually would be amazing for trans people. It's something we're actually really pushing for, and we're pushing for a pilot to be done, and we're actually even speaking about private providers and how they're doing it and trying to update their guidance. So yes, I 100% agree. The problem is that the way the studies are currently being done is they're relying on the current system, which ultimately excludes trans people who are registered as male. So unless they have a sympathetic GP, they're not being put in for this fantastic little pilot. So what we're going to try and do instead is try and do a trans pilot, but due to logistics and funding and time, it might take a while to come around. So this is why we're also thinking about, okay, well, if people are going outside the service, because we're not currently providing everything that is equitable, and they are going to people like, for example, Superdrug's private service, is that still safe? Are they getting the right information? Making sure that all avenues are safe for patients. But I agree, HPV self-swabs would be a fantastic way forward and can really navigate that dysphoria and really deal with those issues of either low attendance or just general avoidance of screening. Yeah. Cool. So I think we're good to move on to the next bit. Yeah. So we've done cervical. Let's think about breast, the other sort of key program. So for trans men who have not had top surgery, so this is, they haven't had the bilateral mastectomy and male chest reconstruction. So regular self-examination is recommended, and we would recommend they continue with normal breast screening. If the registered is female, they'll be invited. And then if the registered is male, their GP should refer them for mammography. When we think about people who have had top surgery, so here you've got a couple of examples of how top surgery can be done. And basically there's a multitude of ways. Sorry, the picture's quite small. Multitude of ways, and effectively it's just reminding you that someone's chest may not look immediately operated on. So we all often think of these quite large scars across the lower section, but actually you can do many different forms. So again, it's not making those assumptions when we see people's bodies. So trans men who've had top surgery can't really go for standard mammography because they won't be able to go into the actual machine, but we can do other forms of screening. And in the meantime, I would just say they should be using a cis-male pattern for self-checking, and also thinking about the tissue that might remain up into the collarbone and in the armpit. Some operations will remove this, so people should know what their own surgeries have done. But if there's any at-risk tissue, especially around the nipple, it's important to make sure you continue to check that. But the breast cancer risk should be slightly reduced, either due to hormone treatments, but also removal of breast tissue. And also thinking about language we use when we talk to patients when we're thinking about this, because again, breast may be a dysphoric trigger because we're using effectively feminine language, whereas actually breast tissue is the language we do use. So you might have to explain to people like, you know, sometimes I'm going to have to speak clinically and use this term, but otherwise we can talk about your chest. And then for trans women, so trans women registered as female, routinely picked up in the screening system, so that's fine. Long-term hormone therapy can increase the risk of developing breast cancer. We normally think this is a risk after a couple of years of being on treatment though. This number sounds high, so I'm just going to preface it with don't worry, but the breast cancer risk might be 46 times greater in trans women compared to cisgender men. So if we think about as someone who began as a cisgender man and now is a trans woman, that's the increase of risk. But this increased risk is no greater than in cisgender women. So it sounds like a lot, but if we think about it with their peers, it's fine. And because of this reason, they can attend normal screening and normal treatments, and it's not a problem. So when we think about it for family history as well, this is where it might get a little bit tricky. So this is where things like BRCA positivity or any sort of history of breast cancer might be a cause for concern. And we might want to think about, okay, are they on hormone treatment that might actually aggravate any potential cancer risk? And again, if they have a tumor that might be androgen or estrogen receptor positive, thinking about how this relates to their gender transition treatments. And this is where, again, on the handout, you'll have the details of my colleague that can weigh in on this sort of stuff and really support. I'm just very happy to do so. So I just want to go straight into changing records because all this stuff sort of leans into that. And firstly, thinking about changing gender and how this works in the records. So some of you might have already done this, but for some, this might be something that you haven't had to come across quite yet. So patients can request to change the gender on their record at any time, and they don't have to have gone through any gender treatments for it. They don't have to have been referred to the GIC. Anybody can do it at any time. So it's up to your GP practice to define your own procedures about this, and if you want to ask for evidence, but there's been a recent change on this that there's no legal requirement to do so. So in the past, people were asking for depols, etc., and now there's actually no legal need to do so. So you may want to do it for your own checks and balances and making sure everything is good internally, but if you're challenged on this, it's important to know that the current guidance says a patient can do it at any point without the need of the legal proof. Obviously, you might still want to get some sort of other post or something, that's fine. And the Records Management Code of Practice is going to update this, but this is information I have directly from NHS Central. So when we think about transferring history, so what happens effectively is when someone does transition and you set up a new record, they get a whole new NHS number and a whole new record. And then you have to take that responsibility to migrate everything across. Now, it's important to point out as well that if someone detransitions or wants to go back to the previous record, you can't actually do that. They'll have to set up a whole new record again. So this process, it's very important to make clear to people what's involved when doing so, not to discourage them in any way, but just to make sure that they understand the importance of maintaining the clinical record. So the wonderful thing to happen would be if they're completely fine with everything being migrated over. That would be great, full complete medical record. If not, you might want to just talk to them about, okay, well, can I remove the name and the gender on the records and just keep all the clinical information on there? The problem with this is you might actually end up still leaving in some gendered information, for example, contraceptive history, etc. And this might give away someone's gender history if someone else was to look at their records. So if somebody then objects to it for that reason, it might be worth saying to them, okay, well, can I summarize the important clinical information in a gender neutral way? So any kind of key operations or causes for concern and keeping those on the record. But some people may decide, no, they want a fresh start and they want to completely protect the gender history. And if that is the case, that's fine. It's ultimately their patient record, but you should get your consent, make it all on a file and make sure you're covered and that they understand the risk that comes with this and the fact that it's therefore their responsibility to keep their medical history for themselves and share it when it's appropriate. Well, then we've got a point for questions. I know there's quite a lot of stuff around medical records, so feel free to jump in for questions. The other thing, I think it comes up in my slides later, but I do want to point out now, when we talk about gender history as well, what we're talking about is effectively the point of pre-transition as we would know it, or the point at which someone identifies to you as a certain gender and anything before that. And the reason this is quite a key concern is because revealing someone's gender history without their permission actually goes against the Gender Recognition Act, which means it's illegal. So we need to be careful about where we're protecting people's gender history and respecting their choice to do certain things like manage their own medical record.
So, Stuart, I've got a couple of questions. So one, just expanding around the virtual clinics. It was just virtual clinics in general. So finding out information around the patient before they come in. And so you are then in a better position to support that patient. So
right, yeah, that makes sense.
Yeah.
Because before I was just like, how are you going to do a swab virtually? So yeah, no, so that's a really, really great point. And doing these kind of pre-checks with people is 100% recommended. If you identify a patient that might need additional support in accessing treatment, a clinic, or whatever, checking in is wonderful. We're actually in the process of internally reviewing a document we're about to release that we call a provider pack, and it has all these handouts and pieces of information that can be really useful. And in that, we have guidance on how to call a trans patient and make sure they're feeling affirmed. So I'll make sure that goes out to everybody when we release it, because things like checking name, making sure people are attending at the right time, getting to explain certain things about the procedure and making sure people feel ready is a wonderful thing to do. Yeah.
And then, thank you. And then there's another question around, can gender transition with a change to the NHS number lead to fraud?
So it's not something that I think I've ever heard of as a start. So I assume that's a good point. And it's not something that I think I would even be able to give a direct or sort of complete answer to. I think this is something that comes much more into sort of central record management and how that works. And again, this does go back to why it's completely fine to have your internal processes. So if you decide that you want to ask for certain points of evidence, do it by all means, but just be aware that if a patient, for example, may not be able to afford legal documentation changes, may not be able to pursue certain things for certain risk, or maybe in a point of housing instability, and they're not able to get these documents to you and they challenge you on this, understanding, okay, well, this is the current NHS position that they're able to change their name regardless and their gender.
Thank you. That's all the questions in the Q&A box at the moment.
Okay, so we've also got a question here. What about prostate cancer risk in trans women? Yeah, okay, so this is actually a good question. So prostate cancer risk, so this is, the reason I didn't put it in is because obviously it's not as part of a national screening program, but it is a very good point. So what we actually see is people who've been on hormones for a while, we tend to see that there's a reduced risk of prostate cancer, much in the same way that the hormones are similar to the ones we use for treatment. However, what sometimes happens in trans women is actually when they do get it, it's more aggressive. So there's a bit of a concern around that. When it comes to things like particular high risk like ethnicity, unfortunately, it's one of those lack of data answers, I'm afraid, because we're looking again at that intersectional issue. So this comes back to what I was saying right from the beginning. If we think intersectionally about where money and research and time goes, very rarely it goes to trans health, and very rarely it goes to Black or people of color health. So if we're trying to put them together and we're trying to actually think about, okay, Black trans people, very little data. So it's something that we definitely try and keep an eye on. There's actually quite a lot of work, much more unsurprisingly, around men who sleep with men prostate stuff. There's quite a lot there, but trans women and prostate health, it's still developing. But when it comes to how it crosses over with higher risk factors, I don't have a complete answer, which if anything is just, I think, more of a push for, we need better studies, effectively better funding. Great. So supporting disclosure. So this all comes down to effectively, okay, we're trying to deal with people's patient records effectively, but we also want to support them, right? And we want to give them the opportunity to tell us who they are. So this comes back to what I just mentioned before. So I just want to point out that red flag point I've got here, that it's unlawful to disclose a patient's gender history without their consent. So what this means is, like I said, someone's gender before you knew them, and this again might be on their record, might not. If you share that without their permission, you're getting in big trouble. And we've got to think about this in the way that we put information on their records and checking, okay, are you comfortable with this going on your record? This record is going to be sent to this clinic. This person's going to see this thing, and just making sure that we are making sure they know where that information is going, especially if they beforehand tried to take everything off their record. Because now you're effectively putting them in a position where they're almost back to square one. So what we often see is patients are forced into disclosure by these heteronormative assumptions. This is like we were seeing with women and cervical screening, you know, assuming that, okay, well, you don't have a male partner, so you don't need this treatment, etc. And the goal really here is just making sure that people feel comfortable enough so they can tell us who they are. So we're not trying to field questions and are you a lesbian? Are you gay? Like, do you do this in your free time? Nothing like that. What we're just trying to say is, tell me about your life. Do you have a partner? Do you have more than one partners? Well, what does your home life look like? Giving people the opportunity to explain themselves works a lot better. And then again, not making assumptions. If someone says, oh yeah, I have a girlfriend and they're a woman, just kind of letting them talk and say, and then or saying, is that typically who you would date? Do you have a history of dating other genders? And giving them an opportunity to explain fully who they are. And again, even in your own practice, if a patient in confidence tells you that they're trans, don't assume this means you can go around the whole practice telling people, check in and say, okay, thanks for telling me that. Do you want it on your record? Or should we just keep it between us? How much can I share that information? And this is also super important when we're thinking about earmarking those records to send people for the correct screening, making sure people understand here, there's a benefit for us here if we're able to record it in some way. So supporting people's disclosure and barriers to people's disclosure. So things that really support disclosure are good communication skills. We've got challenging these heteronormative assumptions we've discussed, using inclusive language. This can sometimes be quite gender neutral language, and this can even go in your posters and your letters when you're saying hello everyone rather than ladies and gentlemen, these kind of things. Another really important thing is open body language. When you're talking to your patient, are you head on? Are you showing them that you're listening? Are you paying lots of attention? Or have you got your shoulder to them the whole time and you're just not really looking? Because I've heard directly from patients who are trans that when they mention they're trans, sometimes this happens. And what people see is, okay, there's a discomfort there. Another thing is obviously if you're perceived to be accepting. So this can be down to your behavior, but also other things you can put around accepting visual cues. Are you wearing a NHS rainbow badge? Do you have a lanyard? Did you have a poster in your waiting room? Or are you LGBT yourself? That can sometimes be a good one. Obviously, we can't expect that from everybody. And we also can't assume that every LGBT healthcare provider knows everything either. Everybody needs to be trained up. So things that are barriers to disclosure, we've got it perceived to be irrelevant. That can be a real issue. So this comes down to patients not understanding the relevance of their own either risk behaviors or medical history or how it intersects or even their gender treatments, because again, there's not enough information out there for people to know their risk. Those heteronormative assumptions, when people see them in practice, we've got the fear of breach of confidentiality. Like I said, this is about protecting gender history. Fear of poorer care and discrimination. This is something I hear quite often. Again, it's not something we would really expect from our colleagues. However, I have heard of people who have been afraid to go into surgery because they were afraid that their surgeon would leave some small cancer inside them. And as horrific as that is, and as much as we want to assume that's not actually going to happen, that patient should never fear that on the basis of who they are as a person. So then we also have healthcare providers being perceived as non-accepting. And this again, it might be because there's either a reputation around a certain place or a clinic, or it might just be assumptions that even the patient is making. I've definitely heard that from some patients, and I have to remind patients to have the best faith in people. But if people have been through healthcare environments before and had bad experiences, we have to understand and respect that and appreciate that we may have to reach further. There's also the lack of knowledge about LGBT issues, and this is obviously why we attend talks like this, and I encourage you to go to even more, and I'll give you some information on others in the handouts. And then also your location and your setting. So in the same way that you can put up really great Stonewall posters, etc., but are there any other things that can make you feel uncomfortable? Is it all super gendered? Do you have a gendered sitting area? You know, these kind of things, thinking about how we can make it better for everybody. Even things like your bathrooms, are they unisex? Do you have gendered male and female bathrooms? You know, is your trans person having to go into the disabled stall all the time? How does that make them feel as a person? What does that do to that implicit bias? So thinking about how to make your environment better, what's the most recognizable LGBT symbol? This is as simple as it sounds, I promise. So feel free to put what you think is the most recognizable symbol out there. Yep, you've got the rainbow. I'm expecting this rainbow word just to get bigger and bigger and bigger on the screen as we all type it in. Good. Okay, so there's a good consensus. And this is quite reassuring to me as someone in the community, especially after the pandemic and the way that things have sort of moved with the way the rainbow's been used. Pink triangle, that's a really interesting one to throw in there, definitely. That's got a lot of history attached to it. So yeah, that's an interesting one to see. Okay, so let's think about that in relation to what we do to our environment. So this is something that I think is a quick win. So firstly, the rainbow is related to positive feelings of identity and self in LGBT people. So we know it works. And we also know that public displays, they promote inclusion and they can also promote disclosure. So there's multiple stories of people seeing a GP with a rainbow pen and then being able to tell them who they are. People who were afraid to do so beforehand are now able to take their partner in and be able to kind of share their care model and who's out there and actually who's really supporting them. It's wonderful to see. The other thing is we're coded to notice these things. We kind of grow up knowing that when we see this thing, it's a safe space. We even do it on our holidays when we go and we look for a rainbow flag in a cafe. It's something we'd see all the time. And before I get on to the final point, I want to point out some ones you can use. So you've got the NHS rainbow badges, you've got our own badge, which you can get via Pinprick, which is a company, and they donate the profits to us, and that's our inclusive cancer ribbon. You've got the NHS lanyards, and in the top corner, you've got the rainbow flag that might look a bit different to how you've normally seen it. So the reason being, we've got the standard rainbow colors, but you've also got these chevrons. So you've got the black and brown, which represent the people of color in our community. And we've also got these other three colors, which represent trans community. And the reason they're on there is because we're trying as a community to be better at the people that are underserved. And the reason there are the chevrons is because they are the progress we need to make and the direction we need to go in towards inclusion. And we call this rainbow the progress rainbow. So if you are worried about, okay, well, how do we differentiate our LGBT inclusion policy and environment compared to the stuff we've had with the pandemic and the nurses, and we still want to support them, it might be worth getting your hands on some progress rainbow stuff and putting that around as it's a way to show that not only are you being inclusive, but you're also aware of like the current stuff that we're actually going for. But also back things up with training. It's really important to have all these policies, but do make sure that you're checking your own internal procedures. You're making sure that you're putting posters up, but make sure everybody knows what they really mean, just so that people who come in are able to actually receive good care. And we see it in quotes. So here we've got quotes of someone saying that seeing something as simple as a poster that shows a same-sex couple and it's not just about sexual health and AIDS would be great. And we also see someone talking about any visible policy or posters making them feel more confident in their doctor. So any quick comments or questions, or shall we run straight into a small exercise?
I've got a couple of questions. So there's one that says, what percentage of trans men present for breast cancer family history within general practice? Don't know if you can answer that at the moment.
Not off the top of my head.
There you go. But obviously, if there's anything that we can direct to people after, then we can do.
Yeah, there's actually a wonderful paper about this. Okay, so actually there's a really good point to make in there. So there's a wonderful paper from De Block on the issues of breast cancer risk in trans men and trans women. And I really encourage people to read that paper. If anyone needs it, I can link it. What I would actually point out is actually because of the NHS record management system currently, because we only record the sex marker and we infer everything else from it, and we see these issues with call and recall and people being pulled up for the right screening, what actually happens is then it's incredibly hard inside our system to see who's affected by what cancer if they're trans, because we don't actually know who's trans in the system. because we're not recording it, we're not able to, like other categories, go back through and say, okay, this is the percentage of people that went through this pathway. And what happens is we tend to have to rely on small either experiments or sort of small pockets of work that can be incredibly heterogeneous between each other's methodologies. So it can be quite hard to pull larger conclusions. So it's a really good question to have, but I think this is why we're stuck in the issue of waiting for science to kind of give us these piecemeal answers, often from cultures that don't necessarily reflect our own. So the De Block study, I think, is in the Netherlands, and there's some stuff in America that happens too. But this is where I'd really pressure anybody to put more pressure on the NHS to say, like, give us a sex and gender category on our records so we can really support our patients.
Thank you, Stuart. And then finally, does Live Through This have any materials I can put up in our practice waiting room or on our website, encouraging trans people to attend for screening and explaining that they remain at risk of certain cancers?
Great question. So it's something we're working on in regards to posters. We were going to do some for the pandemic and get some real pictures of actual patients, but again, everything got sort of slowed down. So it's something, definitely keep in touch with us and we'll let you know as soon as they're available. Up until then, there's some other content that we can sort of refer you to. And Zara and I will actually be doing a stand soon about encouraging cancer screening at events. So hopefully we'll be able to learn some lessons from that or get some content that we can then also send around too.
Sorry, Stuart, I accidentally tried to mute you, to unmute myself, sorry. And just one final question, it said, you mentioned trans men cannot be screened using traditional imaging modalities. Can they be screened another way? Yeah,
definitely. So in the same way that you would send them in for standard radiography of the chest and torso, so that it can definitely be screened. It's just that we can't send them for the normal plate screening.
Thank you.
Cool. So let's move into the activity. So how are we doing for time? Yeah, we've got time. So this is where we're going to hear some patient stories. These are actual patient stories that are being read out by actors. And I want you to think about the person who's coming in, and I want you to think about a couple of things. Firstly, who's involved, what's happening, and why, and just kind of reflect on that for me first.
The nurse said I didn't need a test, so I didn't have one. I later went to my doctor to ask about this, to double check, and my doctor confirmed I didn't need one. I wouldn't mind, but I didn't really want to come out to my nurse. She kept asking about contraception and sex, and I had no choice but to tell her. When I told her, she was very rude and tried to get me out of the treatment room as soon as she could. I'm glad I don't need a smear, as I couldn't go through that again.
Okay, so if we're thinking about that who, what, why, yeah, throw some words out. Yep, heteronormativity, incorrect information, yep, cervical, yep, WSW, yep, rudeness, yep. And this comes back to all the sort of stuff we've been talking about so far, right? So this is what people are actively engaging in, and then why do we expect them to keep coming back, and why do we expect them to access these services? But we need to make it better for them because they are entitled to their screening, and we don't want to have anyone at any additional risk. So disgraceful practice, I would agree. Yep, we've got that implicit bias in there. We've got problems with the attitudes. He's making assumptions. Yeah. And again, this goes back to kind of what I was saying before as well. That person, not only for themselves, is not going to come back, but what are they going to tell their friends? What are they going to tell their partners? You know, they're going to go back and they're going to say the same thing. So we have to think about the duty we have for the community at large, especially when they don't have any other health information out there, which is something we're working on. But in the meantime, we need to be better ourselves. So quickly then thinking, okay, well, what would you do differently? So whether you saw this in your practice and you saw that happen, would you interject? What would you do? Or how would you make sure this doesn't happen at all? Yeah, no assumptions. Yeah, definitely. Yeah, correct information being available. Definitely educating the staff. Thank you about the training. Yeah. I think that's a great point as well. We've got this one here, educate staff, but educating yourself and sharing that learning is really key. And I think sharing that learning across all levels of staff, you know, even through to administration, just so that if anybody presents, making sure that everybody knows what services everyone's entitled to and there's no misinformation being sent out there. Yeah, and providing the correct info. And I think as well, making sure that the information that you have in your practice is inclusive. And you can even write in there that it states, you know, even if you are a lesbian or bisexual, you should still be attending this, you know. I think sometimes people are afraid to bring these things up, probably because we're all living in the shadow of Section 28. But the reality is we have to tell people, okay, well, these are the real health barriers and we're aware these exist and we're trying to help you get past them. Great, so let's move on to the next one we've got. So for the next one, we're going to hear from another story. And again, I want to remind you, this is a real story from primary care, and this is an actor reading it out.
I'd met two health professionals who expressed strong moral objections to the existence of transgender people and refused to treat me and recommended religion as conversion treatment. I was scared I might encounter someone with a similar mindset who would use the screening as a chance to assault me.
Okay, so again, we're still talking about Cervical at this point, but thinking about what's happened here. So who was involved, what happened, and why? Yeah, very unprofessional behavior. Yeah, I would agree. Outrageous. Conversion therapy, yep. And that's obviously a very key thing that's happening at the moment in the press. So we have to think as well, not only is this happening, but what is this doing to our patients, especially if a patient has had that experience and now all in the press, all they're hearing about conversion therapy, what kind of trauma and stress they're going through and how likely are they then to attend? What kind of fears are they going to have in joining healthcare again? Not led by evidence, yep. Very transphobic. WTF, I would agree with that one. Yeah, pretty awful, right? Pretty awful all around. And it's a shame that, you know, these things are genuinely happening out there. As again, this is a real patient story. So then thinking about you, again, what would you do differently? What would you do in your practice to make sure this never happens? Or again, from another perspective, what if you heard of this happening from one of your colleagues? Would you step in? Yeah, policies, making sure your policies are very inclusive. Training again. Yeah, challenge behavior. Yeah, correct guidance from different medical councils and GP stuff. And this is also where it's really important as well. If you actually go away and look, there is quite a lot of available information and policy documents out there that are really well written, good codes of practice. So sometimes it's just making sure that we're up to date on them and that we're making sure that everybody in the practice is reviewing them as well. Treatment people respect, 100%. Yeah, and I'm very happy to see lots of people saying they would challenge this behavior because it's very important. And when we think about the levels of power that are involved when you're a patient, it's very hard to speak upwards. But if you see people standing up for you and you're able to challenge people on your level, it's really going to support patients. And I've been saying that for a long time. And we've had this talk even with BMA and stuff, like it's making sure that people are willing to challenge their colleagues where patients may not have the power to do so. All right, so some next steps thinking about it. So some positive actions, thinking about, firstly, get comfortable with the language and pronouns. I know that maybe feels like ages ago we spoke about that in this talk, but it's the starting point. Have some fluency in the way you talk. It's going to make people feel like you're saying it all the time and it's normal to you, and it's a very easy thing. And then review your policies and procedures. You know, policies aren't set in stone. They're supposed to reflect your practices and how you're keeping everyone safe. So if you feel like your policy could be misinterpreted or it's not explicit enough about LGBT issues, write something in there. Make sure that you're really helping people. We want to support safe disclosure and monitoring. So safe disclosure, give people the opportunity to tell you who they are, but also that monitoring factor. Whilst we're waiting for NHS records to catch up and put gender on there as well, have some internal records and think, okay, does the patient know how it's working? Is it safe? Are we able to support their access to screening? And then modifying your clinic environment, those quick wins. Can we get a good poster out there? Stonewall have some free posters. I'll try and remember to send them around for people. And also looking at your local community groups, having a look in your immediate area. Do they have something? Are you able to support them or show some small events or groups they're holding? And then the last thing I want to kind of leave you with is this idea of active allyship. So my personal view is, over time, we've all kind of, some come to say we're allies, but what have we really done to make things better? And we have to think, okay, if we see people struggling with barriers to equitable care, what are we going to do to make it better? And a really good reflective process to think about whether you're actually doing this correctly is thinking, when was the last time someone identified me as an ally or said thank you? So I think that's a really good rule of thumb to be holding ourselves to. Cool. And then we've got just an opportunity for the last 10 minutes for any other questions. I'm happy for you to pick my brains. And there's a full-on fight going on outside, so I hope you don't catch any of that instead.
Stuart, I've got a question around resources and support that we'll send out, so links to people who attended the webinar. What will people receive?
So what you're going to get is, we're going to give you a glossary. We're going to give you the pathway model, so you can think about that process and how we can reflect on that. We're also going to give you a bunch of resource links. So this will be things like the RCGP LGBT Learning Hub, but also things like the Pride in Practice program, some other things you might have heard of. There's some other places to get a bit more information, especially because I think it's very easy to say, okay, we need to train, but then where do you look, you know, and there's not enough stuff out there ultimately. So we're going to give you some pointers of where to go for that, as well as some other pages that other charities and organizations have put together that can give you that immediate boost of information. And then also some local support groups and stuff as well, so you can support patients immediately.
Thank you. So someone has said, social prescribing seems key to address some of this.
Mm-hmm. Yeah, very much agree. And obviously we've got these navigators turning up and we're thinking of it in this context, but my stress to social prescribers is get to know the local community. So reach out to the local LGBT orgs and also then, you know, straddle both sides, because ultimately that patient is going to be dealing with their own health and they may not have time to find all these additional resources. But if you're ready and you're able to support them, and not every LGBT person is going to know every LGBT organization, because that's not where they spend their time ultimately, they're just living their lives. So if you're able to get out there and get to know Spectra, get to know Clinic U, get to know No Barriers Project, all these places, so that the moment something comes up, you're ready. And if you're not ready, work with them and just say, okay, what do you need? I'm going to go away and I'm going to ask. And you can always come to us and say, hey, I've got this patient, what can we do?
Thank you. And I think that touches upon, everyone would have been sent the pre-survey that was sent out to people who registered. And what our aim is to gather all of that information before this webinar and then afterwards, and really understand the needs of primary care in South East London. So I think it's just a plea from me really for the people who are on this webinar, you know, if there's anything that the Alliance can do in order to support you guys, then please let us know. We work really closely with Stewart, and all we want to do is support you in order to make sure that, you know, we're providing as much support as possible for our LGBT plus patients.
Yeah, and also I do think there's a really great lesson to learn here in the working relationship that our charity has had with Selka. It's been wonderful, and it shows that with the right intention and commitment and resource, you're able to do some fantastic things. So if ever you are in a position as a practice and you're like, okay, we want to do this stuff, but we don't know where to start, team up with a local organization, set up your local focus group, or set up a small PPI or something that gets people in, and work with the community to make sure you're meeting their needs. Ultimately, you can always reach out to us, but we have our limited capacity. So making sure that you're taking some of your own initiations and action, and yeah, it should really help you ingrain yourself in the community as well. It's really nice as well to see that those scores have gone up. That's obviously what we're looking for, and especially comfort and awareness. You know, it's really nice to know that people are going to be feeling readier to go back out there and support their patients.
And Stuart, you've just had you've just had wonderful feedback around the session, and people have just said how informative it's been from an extremely passionate person, and an extremely knowledgeable person as well. So yeah, it's really lovely to see.
Good. I mean, I'm always incredibly grateful for every room I get into, because I know that we don't often get to speak as people. And I forgot to mention that I'm a patient. You know, I have chronic myeloid leukemia, so I've been through these processes as the patient and now the provider. So, you know, and it's important even for me to remember that I don't know everything, because there's other people in my community. So it's making sure that we can get those voices up, which is why we give you these patient stories. And it's also reminding you that we're still here, we're a charity, we exist. And if there's any more information you need, just link up with us. Even if you have a very specific issue and you're not sure where to pursue it, we'll do our best to link you up with people across the country that we know.